Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 4, all about clinical assessment, diagnosis, and treatment. When we are thinking about clinical assessment, it's important for us to consider what it means to understand abnormal behaviors by being able to collect information to reach a conclusion. And that's what an assessment helps us to do. It's an idiographic information tool that will allow us to gather symptoms and behaviors so that we can better understand the abnormal actions of the individual before us. It also helps us with a clinical assessment because when we're doing a clinical assessment, we are using that information so that we can figure out the who, what, when, why, how, and whether the person who is behaving abnormally can be supported. We want to find out the duration of time. Is this something that has been occurring for a longer period of time or a shorter period of time? Meaning, is it chronic or acute? We want to find out what the actual symptoms are. We want to find out if this is something that is also a pattern of behavior in previous family members. Is there subsequent issues that, like medical issues or other mental health issues that may be impacting this, like the use of substances or disordered eating or a family history of violence? So the clinical assessment will help us to understand how and why a person engages in the behaviors they do. There are hundreds of clinical assessment tools that have been developed, and they typically fall into one of three categories. There's clinical interviews, tests, and observations. And the specific tool that's used in an assessment will depend on the clinician's theoretical orientation. When we look at the characteristics of assessment tools, they typically have to be standardized and have to have clear reliability and validity. So, what does all of this mean? Well, in order for it to be standardized or to have standardization, this is a technique that involves setting up common steps to be followed whenever it's administered. And that when you talk about the standardized administration, there's also scoring and interpretation that's already laid out for the person administering this assessment. And then we have reliability. This is the consistency of a assessment tool. And a good tool will always yield the same result in the same situation. There's two types of reliability. There's test retest reliability and inter-rater reliability. Test retest reliability yields the same results every time it's given to the same people. Inter-rater reliability is where there are different where the person or the people who are administering this tool are essentially looking at the results independently and they agree how to score and interpret a particular tool. Then we have validity. And with validity, this is the accuracy of a tool's results. And typically, an assessment tool must measure what it's supposed to measure. And there's three specific types of validity. There's face validity, which is a tool that appears to measure what it's supposed to measure, and it doesn't necessarily include true validity. There's predictive validity, which is where a tool accurately predicts future characteristics or behavior, and concurrent validity, which is where a tool's results agree with the independent measures assessing a similar characteristic or behavior. As noted earlier, we also have clinical interviews, and these are typically done face to face, whether it's in person or done virtually over a HIPAA compliant system. And you gather basic background data with specific theoretical focus, like using a cognitive behavioral modality or using aspects from narrative therapy or a psychoanalytic perspective. When you talk about clinical interviews, they can be structured or unstructured. An unstructured clinical interview is where you don't have any preset questions. A structured interview is where you have the same questions that you administer to every person. An example of a structured exam would be the mental status exam. When we think about clinical interviews, there are some limitations. In many situations, clinical interviews lack validity or accuracy simply because when you are looking at the the fact that you're using it as either being structured or unstructured, and we think about the definition of validity, especially if it's unstructured, it's not going to have a lot of accuracy because you're asking different questions to different people based on what their responses are. The interviewer may also be biased or make mistakes in their interpretation of the information presented to them, and typically clinical interviews will lack reliability. Then we have clinical tests. And when we think about clinical tests, these tests are used to gather information about psychological functioning from where broader information is inferred. And you're going to find that there are different types of tests that you can administer. We have projective tests, and these require client interpretation of vague or ambiguous stimuli or open ended instruction. And this is definitely a psychodynamic orientation. The four major tests that we find that are projective are the Rorschach test, the TAT or thematic appreciation test, the sentence completion test, and drawing. So what we see here before us is the how the works of art may sometimes be used as an informal projective test. When we're thinking about this thematic assessment, we can think, as part of the sentence completion test, could be, or excuse me, the thematic appreciation test on the left hand side. You are asking someone to interpret what is happening in this conversation, and the outcomes will vary. And it's really up to the person who is administering the TAT or thematic appreciation test to make a determination based on the respondent's responses, whether it is something that is viable or not. When you look at the sentence completion test on the right hand side, you would give them something like, I wish, or my father. And based on the respondent's answers, the person administering the test would then give their interpretation of those answers. And very rarely are the two answers for the complete thematic appreciation test or the sentence completion test absolutely the same from between respondents. There are similarities, but I've never known where every question that has been asked or every response is completely the same between two people. When we think about drawing tests, they're commonly used to assess the psychological functioning of children. And when we look at the therapy program that's administered by UNICEF, we're seeing here that this young Nigerian refugee draws an attack scene. And when we think about this, the program that was developed by UNICEF is provided in Bagasola, which is a town in western Chad that welcomes people who have fled extremist groups in northeastern Nigeria. So when we see these depictions by a young man, like what you see before us with the Nigerian refugee, this is not unfortunately an uncommon scene, but it gives the interpreters the understanding of some of the violence that these young individuals have undergone. Therefore, we can then provide supports for them to help them process and then live healthy lives. And there's strengths and limitations. And you're going to see in table 4.1 more information about some multicultural hotspots in assessment and diagnosis. But when we're looking at the strengths and limitations, some strengths are that these are some commonly used tests for personality assessments, and it can help us as interpreters and as helpers to gain some supplementary information that we might not get from asking someone, a specific question related to whatever their concern is. But you're giving them an opportunity to process externally, not internally. And by processing externally, it takes some of the emotion that's tied to it and brings it outside of themselves. But limitations are that reliability and validity is not consistent, and it can be biased against minority ethnic groups. And again, table 4.1 in your book will show you some more information about that. Something else to think about too is in 2009, there were some leaks, so to speak. So in an emergency room, there was a physician who had posted all 10 of the Rorschach cards on Wikipedia. And many psychologists argue that the test responses of the patients who have been previously, might have gone to Wikipedia to see these Rorschach cards, which were once guarded and protected, that those results can't be trusted because now they've been able to see information about it. And from people posting their personal responses to it, it now allows them to to essentially make up their own story or to make up a response that is quote unquote most closely aligned with what they believe the psychologist wants. So, when you think about this, do you think that the Rorschach debate has led to an increase in the distribution of psychological tests? I want you to process that and think about that. Now let's look at inventories. So, when we think about personality inventories, these are designed to measure broad personality characteristics, and they look at things like behaviors, beliefs, and feelings. And it's usually based on self reported responses. The most widely used personality inventory is the MMPI 2. And the MMPI 2 is the Minnesota Multiphasic Personality Inventory. So the MMPI 2, which is revised in 89, is typically used on adults, and the MMPI-A is for adolescents. And what it does is it looks at 10 clinical scales, what you see before us. And you look at the scoring from this, and the score is from 0 to 120. If the individual or the respondent has a score of 70 or above, they are considered deviant. And then they have to be graphed to create what's known as a profile. So, what are some of the strengths and limitations of this? Well, when you think about personality inventories, it's easier, cheaper, and faster to administer than projective tests. And there's typically an objectivity around scoring and standardization, and it has greater validity than projective tests, but still can't be considered highly valid because every individual who responds is different. The measured traits often can't be directly examined, and many of these tests don't allow for cultural differences in responses, which leads us to response inventories. And it's usually based on specifically reported responses that are self identified by the respondent. And it typically focuses on one specific area of functioning. So it can be affective inventories like the BDI2 or Beck Depression Inventory 2, a social skills inventory, or a cognitive inventory. And when we think about these response inventories, they typically have very strong validity because they've been utilized consistently for longer periods of time, meaning that there's more people who have utilized these types of tests. And in utilizing these tests, there's more empirical evidence to back it up. Not all of these response inventories, however, have been subjected to careful standardization, reliability, and or validity procedures. So, for example, the Beck Depression Inventory 2 and some others are few exceptions because they've been used so much and have a lot of empirical evidence to back it up. When we look at psychological, some additional clinical tests, we also have psychophysiological tests. And these measure the physiological responses as an indication of psychological problems. So that's going to include changes in heart rate, blood pressure, body temperature, skin response, and muscular contraction. An example of this would be a polygraph test. The polygraphs, for example, and other psychophysiological tests, they require expensive equipment that must be tuned and maintained, but they can also be inaccurate and unreliable. When we think about polygraphs, um, these are still used today, but they're much less trusted. So you'll see that people like the FBI and cops and other law enforcement agencies and the criminal justice system will use some of these responses, but you can easily fake your scores, meaning that you can train yourself to not have as much of an emotional response, meaning that you won't have the psychological or emotional response, meaning you then won't have, once you train yourself, you won't have as much of a physiological response. So you can have a lot of false scores. Something else to think about too is that despite the evidence that these tests are invalid, they are still widely used. And what you see before us is a business in Colombia that the employee is essentially taking this test, but they can still fudge their outcomes. Between 1 and 4 out of 10 truths are called lies on polygraph results, yet polygraphs are still used by the FBI and other law enforcement agencies and even public sector institutions. So you've got me. Then we look at clinical tests. And when you think about clinical tests, you're going to find that these are neurological tests that directly assess brain function by directly assessing brain structure and activity. And some of these are going to include an EEG and a PET scan, a CT scan, an MRI, and a functioning MRI. When you look at the brain, what you see here is different images that will produce different aspects of functioning within the brain. And that can also help us to get a better understanding of how the individual is functioning. Neurophysiological tests are indirectly assessing these brain functions because they look at cognitive, perceptual, and motor functioning. So, an example of this could be the Bender Visual Motor Gestalt test. And when we are thinking about this test, we are noting that as a psychological or neuropsychological test, it helps to assess visual motor functioning, developmental disorders, and other neurological impairments, especially in children 3 years of age and older. And what ends up happening is that there are different tests, and these tests consist of 9 index cards where you put different geometric designs, and the cards are presented individually, and test subjects are asked to copy the design before the next card is shown. Test results are scored based on the accuracy and organization of their reproduction of this of these representations of the cards. Clinicians will often use a battery of tests when they're trying to find out certain key pieces of information, and neuropsychological tests being one of them. We also have intelligence tests, and these are designed to indirectly measure intellectual ability. And they consist of a series of tests that are both verbal and nonverbal in assessing their skills and in utilizing these skills. When you look at the outcome, the general score is what's called the intelligence quotient or IQ, and this represents the ratio of a person's mental age to their chronological age. When you think about intelligence tests, they are among the most carefully produced of all clinical tests. They are highly standardized by a large group of people and they have very high reliability and validity. However, performance can be influenced by non intelligence. Tests may contain cultural biases in language or asking to complete certain tasks. And members of minority groups may have less experience and might be less comfortable with these types of tests, which influence their results. When you are nervous or uncomfortable, you typically tend to score lower on exams. We also have clinical observations, and we have naturalistic and analog observations. When we're looking at naturalistic observations, they can occur in everyday environments. They can occur in homes, schools, and institutions like hospitals and prisons, and even community settings. Most naturalistic observations will focus on parent child, sibling child, or teacher child interactions. And there's reliability and validity concerns that are raised by this because the interpretation is based on the individual administering this test. If naturalistic observation is impractical and you can't do it, then an analog observation is used and conducted in an artificial setting. So you will simulate a similar experience of a classroom or a bedroom or a kitchen in a lab versus going to the person's house or classroom. We also have self monitoring, and this is when people observe themselves and carefully record the frequency of behaviors or feelings or thoughts as they occur over time. And it's useful in assessing infrequency or over frequency in reporting behaviors. And it can provide a mean of measuring private thoughts or perceptions. But validity is a concern because the accuracy of filling out these, for example, a behavior modification chart might be not they might be recording too much or not recording enough, or that what you are intending to record is not in fact what's actually being recorded. So we get this information. Let's talk about now taking these symptoms and coming up with a diagnosis. So typically when we think about coming up with a diagnosis, everything that's completed is done on a classification system. You want to use all available information in order to then make a diagnosis. And what the clinician will then do is to paint this clinical picture to talk about what might be the issue or concern of the client. And a determination can talk about what these symptoms or what the information that was presented, what might the psychological problem be of the client. And you take what you have found based on the information that you've gathered using an existing classification system and influenced by the clinician's theoretical orientation to not only paint this picture, but then to identify, okay, this is the cluster of symptoms that fall under this diagnosis. In North America and around the world, we use what's called the Diagnostic and Statistics Manual um, of Mental Disorders, or the DSM-5. We also have two other diagnostic systems, and that's the International Classification of Disorders, or ICD, and the Research Domain Criteria, or RDOC. The DSM-5 and the ICD-10 are typically used in the United States in order to talk about mental health and medical issues, respectively. As stated, the DSM-5 was instituted in October of 2013, but it was not made a mandatory tool to utilize until 2015. But it is most often used in the US, and it lists different categories, disorders, and symptom descriptions with guidelines for how to assign different diagnoses. And the focus is on clusters of symptoms or syndromes versus individual issues themselves. And the ICD-10 is used in most other countries, but it can match with some DSM-5 diagnoses. The DSM-5 typically requires a clinician to provide both categorical and dimensional information as part of a proper diagnosis. So categorical information would be the category or the disorder that's indicated by the symptoms, and the dimensional information is looking at the symptoms and the severity of these symptoms and how much, based on the severity of the symptoms, how much does it impact a person's ability to function. When you think about the DSM-5 categorical information, as we will now see in future chapters, we look at things like anxiety disorders and depressive disorders as just a few um, examples of categorical information. When we think about the dimensional information, we are looking at the severity and the ratings. So we want to see, how does it impact your ADLs or activities of daily living? How does it impact your relationships, romantic or interpersonal relationships, family, friend, coworkers, work, etc. So we look at the cross-cutting symptoms measure and the emotional distress depression scale as some examples. When we look at the efficacy of the classification system, some things to think about is that the framers of the DSM-5 followed certain procedures in their development of the new manual to help ensure that the DSM-5 would have greater reliability than previous DSMs. The number of new diagnostic criteria and categories were developed with the expectation that the new criteria and categories would be reliable. And some critics continue to have concerns about the procedures that were used in the development of the DSM-5. And it should be noted that the APA was sued before the DSM-5 even came out to start reorganizing and recategorizing and adding additional pieces of information within the DSM-5. So what we see here are some of the top 5 DSM-5 concerns. So based on these concerns that you can read, there's been a call and change. So major depressive disorder and recent bereavement should be separated. Premenstrual dysphoric disorder should have its own separate category. Somatic symptom disorder should have its own category. There should be a combination of patterns into single substance use disorder. Gambling disorder category should be placed within the DSM-5. Autism spectrum disorder should have its own separate category. And finally, that there needs to be mild neurocognitive disorder and aging. That should be separate. As we've talked about previously, can diagnosis and labeling cause harm? Yes. So the way in which we utilize language and the way in which we offer a diagnosis can certainly cloud or impact a person's functioning, because they will take these diagnoses and it can become a crutch, or it can become part of their identity, which might not be helpful for the client. And the language in which we use can actually be damaging or harmful to the client and their self-concept and their self-esteem. It can also lead to stigmas and self-fulfilling prophecies. Well, if you think this is what I am, might not think this is what I am, but if you say I am, then I might as well live up to it. When we think about treatment, right? So we've now done the diagnosis, we've gotten the information, in the assessments, we have gotten the diagnosis information, and now it's talking about how to treat them. So, how do we even begin? So, you begin with the assessment information, and then you take the diagnostic decisions to help formulate a treatment plan. And remember that you are using information from the assessment and from the diagnosis in order to come up with a treatment plan. It also must be co collaborative, meaning that you need to get buy in from the client that you are working with or clients that you're working with. Because without this information, there's really not going to be any progress in um, there's not going to be any progress in their treatment. You also need to include other things like what does the current research say is helpful for treatment? What is the therapist's theoretical orientation? And looking at empirically supported and evidence based treatment options, as well as complementary and alternative options. So, when you think about therapy outcomes, which factors should contribute to therapy? Well, according to research, a client's progress in therapy will relate only partially to the specific strategies used by their therapist. In fact, factors like the client's expectations and the therapeutic relationship and concurrent events in the client's life actually have more influence on the outcome of treatment, which is what we see here. So, when we think about the efficacy, you want to think about how do we define success? How are we going to measure improvement? And how does the variety and complexity of treatments influence the effectiveness of the evaluation? So, these outcome studies typically will ask these three questions. Is the therapy that we want to use effective? Are there therapies that are generally effective? And are there particular therapies that are effective for particular problems? These are all things that you're going to have to research when formulating a treatment plan. So, when we think about the clinical assessment and we're actually coming up with the physical treatment plan, what lies ahead? We need to look at properly being able to diagnose and effectively treat individuals. And the clinical assessment is definitely helpful in properly diagnosing and effectively treating someone. We also can consider that brain scanning techniques continue to offer assessment information about an increasing range of psychological disorders, especially those who have cognitive impairments and or are older. By being able to have brain scanning techniques that we can be able to see where there's a potential decline so we can now support our client and potentially their loved ones. It's also important for us to think too that there are rising costs and healthcare concerns and economic factors that may limit the use of certain assessment tools. So we may have to begin to become creative when we are interviewing, assessing, diagnosing, and treating our clients. I hope that this is helpful for you. As always, if you have any questions, comments, or concerns, please feel free to reach out to me via email. In the description box below is your extra credit question. All you need to do is answer the question in the comment section, take a screenshot, and upload it to Canvas for up to 1 point added to your final grade. Don't forget it's due by Sunday at 11:59 p.m. Until next time, I hope that you have a great one and be well.